I always ask the patient, so who do we treat, the MRI or the patient? How about we treat you? Let's treat you. You tell me where the pain is. And then if they say, well, it's mainly my back, okay, well, that's a certain type of injections. And the injections will do two things for the patient. Number one, make a diagnosis. Where is the pain coming from? An MRI doesn't tell me that. It could tell me a lot of things, but it doesn't tell me specifically where. But if I can take a needle, your whole world opened up, because now we know where to send you for physical therapy or chiropractic. Do this technique for that patient, do that technique. So that's a big help. And more importantly, not only is it diagnostic, where's it coming from, but therapeutic, i.e. make me better. It's a therapy.
Well, when people hear pain management, some people think medications, some people think injections, and sometimes they put injections in just one category. Yeah, I just got a pain management shot, right?
Right.
But okay, which one? Where? How many? And let's talk about it and let's decipher it for people.
So for those patients who just have the back pain, most likely it's called a facet injection. Been around since the 50s. And again, what you would do, go to a physician. They would have most likely a fluoroscopy suite in their office to keep the cost to a minimum. You get an injection directly under local anesthesia. So what you would do under x-ray guidance, I would touch the patient under x-ray. Is this where the pain is? I can see it under x-ray. That's my target. 2 bee stings, done. Now let's just say the patient say, well, you know what? It's in my back, but it's sciatica. When you say the word sciatica, by definition, you mean down the leg, runs all the way down like a lightning bolt. So we know that's a nerve always. And then we'll know what particular nerve is involved. And if that's the case, simple idea, x-ray room, clean your back off, find the hole where that nerve comes out of, inject the steroid medications there, done. Pain score is down, but I like to hear about your functionality. Oh yeah, I'm still a 10, but no, I'm back to the gym. I'm doing my house cleaning. I'm doing the kids with the mall and all that. That's what I care about, is your functionality. So to your point, when someone comes to me with a bag of pills, I always ask, it's very confusing. Most of my patients are older. I mean, let's simplify things. Do you need all these medications? And the answer is probably no. So let's find out things that are going to work for you. But the other aspect is, about 5 years ago, I start to see a real problem with addiction. Now, a lot of these patients had no real intention to become addicted to these medications. It was not their fault. It wasn't the physician's fault, but it's what happened. So because of that, I became board certified in addiction medicine.
Interesting to see the spacer for facets, right? So we are talking about something that is also minimally invasive, still can have long-term effect, can be, in contrary to fusion, can be removed if needed.
I want to make sure I can reverse if we have a trouble. Most surgeries you can't reverse. You buy the whole enchilada hoping for a good outcome. And if it doesn't work, oh, well, we tried. So you always want to be, especially with pain patients, where this is a therapy that can help. But if you don't like it, we can reverse it and you're anatomically the same. And that's a really key factor. So with the spacer, basically all of that does, it goes in between the two bones, separates them like that, kind of recreates that height for that nerve to kind of come out of. And that's essentially it. I think the biggest thing, a tagline I would really focus on, is don't give up hope. So often I see patients that come to me and I'm really no better than the next guy, but for whatever reason, through listening to the patient, maybe adding a different medication or doing a different procedure or something, integrating with another physician or another provider, acupuncture, chiropractor, somebody else, all of a sudden there's a window of hope that just opened up for this patient. So we're all working together on the betterment of that one patient.
Welcome to Polish Your Life. Today, we're going to talk about pain management, and pain management in the context of integrative medicine, where providers collaborate, they work together, they refer to each other, they share clinical experience and all that to get you or your patients the best results. I'm here with a very, very special guest, and it's so important to work with the right people. It's so important to practice pain management the right way, because so many people are suffering, and most of the time needlessly, because they can be helped. So today we're going to be talking about integrative medicine. You'll be learning a lot because we're going to be answering frequently asked questions. We'll be talking about advancement in technology and also what our favorite provider in pain management in Washington, D.C. is currently doing to help the patients. So who is with us today? It's Dr. John Dombrowski, who is a board certified physician in pain management, anesthesiology. He is also board certified in addiction management, which is so important to mention because pain management needs to be practiced the right way. You'll be learning a lot, so share this video with others, ask questions in comments below if you have any questions to Dr. John, and help me in welcoming Dr. John Dombrowski. Welcome to Polish Your Life.
Thank you so much for having me as your guest. I really appreciate this opportunity to talk to you, but more importantly, to the viewership on this video. It's incredibly important to get the message out. I think the biggest thing, a tagline I would really focus on is don't give up hope. So often I see patients that come to me and I'm really no better than the next guy, but for whatever reason, through listening to the patient, maybe adding a different medication or doing a different procedure or something, integrating with another physician or another provider, acupuncture, chiropractor, somebody else, all of a sudden there's a window of hope that just opened up for this patient. And that just gives them that glimmer, don't give up. I think it's so sad when people come to me with the being depressed, a sleep disturbance, and obviously their whole life is tragic. But now we can put their life back together again. You see, there is hope for you. And then success begets success. And so often in life, we see failure beget failure, and then that often leads to depression, anxiety, and makes your pain worse. And I think the point is in this video is to let people know there's always hope. And whether it's through medication or another provider, that's really key.
I love it. I love it. And it's so true because a lot of people are losing that hope. So if you know somebody like that, just remember that with the right approach and also teamwork, truly magical things can happen. Dr. John, if you don't mind, tell our viewers who don't know a lot about you, a little bit about yourself, your background, what people should know before they see you.
So obviously I'm a physician. I grew up here locally. I'm in Washington, native Washingtonian. Went to O'Connell High School and then went to University of Richmond in Richmond, Virginia. Then I got a master's in physiology at Georgetown. And then I did my medical school training at Georgetown as well. After that, I went to Yale and did a subspecialty training in anesthesiology as well as pain medicine. I had a private practice down in Richmond, Virginia. And then we had the opportunity, 25 years ago, to come back home to DC with my family. And I was working at Silby for, my goodness, 10 years. And then about 15 years ago, just really went on my own to specialize in treatment of pain medicine and taking care of patients with pain, obviously not only with medication management, but more importantly, injection therapy and implant therapy. The other aspect is about 5 years ago, I start to see a real problem with addiction. Now, a lot of these patients had no real intention to become addicted to these medications. It was not their fault. It wasn't the physician's fault. But it's what happened. So because of that, I became board certified in addiction medicine, running, a detox facility called Tranquility Woods, which is excellent in Pasadena, Maryland, as well as several methadone clinics throughout the state of Maryland. Because I really see as physicians, we have a responsibility for these patients, not only with their medication management, but also if they get in trouble, that we need to make sure that they have a safe off-ramp but still take care of their pain. We realize opiate therapy may not be the right thing for them because of their addiction, but now we realize that we can still care for you, but perhaps not that way. So that's been my background. My practice in upper Northwest DC, up in near American University. We take all insurances. Again, everyone deserves care. Maybe a little bit about my practice that's a little bit different than most is that there's no nurse practitioners, PAs. If you want to talk to the physician, just start talking. It's more kind of 1950s medicine in terms of sitting down, talking to somebody, just not looking at x-rays or having your hand on the doorknob, because this way you really get an understanding of what the patient wants. And I try to make them understand, I'm not Jesus. I can't make everything better. But if we can make a little bit better, what would that thing be for you? So many times women say, I just want to clean the house. I mean, I can't believe that's their dream, but that's what they want to do. And I go, okay, how do we obtain that goal? And then we come up with a plan that they can actually do that. Or you know what, I just want to spend a little more time with my grandkids or go to the mall, just walk a little bit longer. Do you still have the pain? Yes. But is my functionality better? Well, yeah. So actually we made a success for you. So we have to make sure that we have realistic goals for the patient and that we both can agree on. And then when we have a successful goal, most likely we can get you there in terms of your functionality.
I love that. And it's so important because we can get the pain scale, reduced from a 10 to a 9 to an 8 to a 6, and then the quality of life changes so much. So it means a lot, and it's not always like the 0-1 approach that it's either here or not. So I love it, and it's very meaningful because, as we all know, because at some point in life everybody experiences pain, whether it's emotional pain, physical pain, whether it's chronic or it's acute. When you have pain, you can function, you can think, you can do your business, you can do the things you love to do, take care of family. So there is a lot of meaning behind this video that I want people to also feel and experience, that when you practice pain management, there is hope for a lot of people who actually lost hope. And in the context of medication, because you mentioned the 1950s approach, which I love, because you talk about the relationship between the physician and the patient, where a lot of times you can see the models of pain management clinics that will be extremely busy with tons of assistants, but sometimes it's working well, sometimes the patient will feel disconnected from the physician. And especially when it comes to pain management, that connection is very important, because it's the level of trust you have.
And I agree. And the ones who really do this the best, and that I've really learned a lot from, are from chiropractors as well as physical therapists. They're always touching the patient. You know, we as physicians, I mean, that's their work. That's what they do. They manipulate, pull, tug. I don't know what they do, but they're always touching somebody. And we're human beings, and being touched in an appropriate way is very soothing, you know, because we want to help you. So often I think physicians who are MDs or DOs have a belief that physician and patient might be on different sides of the aisle. You're my adversary, so I have to be cautious what I say or what I do. Maybe I should be that way. So we're very skeptical. So we really don't have a great relationship, because we always view that patient as a potential threat. Well, I don't believe as patients as threats. You know, we have to understand, and people always want to say, well, let's get an MRI, let's do testing. I go, how about we just talk to people? You know, MRIs are great. They certainly have their role in terms of surgery and changing someone's anatomy. But most of the time, you just need to talk to people, because how did people get care years ago without these fancy tests? And they're great. The doctor did a history and a physical exam. It sounds so simple, but the patient can diagnose what their problem is. So often I will say to a patient, well, the MRI says my pain's on the right, but really it's on my left. So I always ask the patient, so who do we treat, the MRI or the patient? How about we treat you? Let's treat you. You tell me where the pain is. And then if they say, well, it's mainly my back, okay, well, that's a certain type of injections. And the injections will do two things for the patient. Number one, make a diagnosis. Where is the pain coming from? An MRI doesn't tell me that. It could tell me a lot of things, but it doesn't tell me specifically where. But if I can take a needle or do some type of procedure and place it in a certain area under x-ray guidance, or think, you know, of a skill set, and you're better, well, now you have a diagnosis. Your whole world opened up, because now we know where to send you for physical therapy or chiropractic. Do this technique for that patient. Do that technique. So that's a big help. And more importantly, not only is it diagnostic, where's it coming from, but therapeutic, i.e. make me better. It's a therapy. So that's the other key thing. And rarely do we ever get things with one modality. Just like with cooking, I always use this as a great example. Cooking, we use salt. Salt is always great. But normally, if it doesn't taste right, we don't add more salt. That's like sometimes you go to a physician, well, that medicine didn't work. Well, you just need more of the same medicine. So hammer, nail, or you just need a bigger hammer. No, maybe I need a different tool, maybe a different spice. So I'm going to add oregano, tarragon, basil, whatever you want for your chicken dish. But we always add something else. And that's what we do in the practice of pain medicine, in terms of just don't add an injection. But most patients always walk out with a prescription for some physical therapy, chiropractic manipulations, or other medications that, you know, don't really have any addictive potentials. And that's the other key factors. It's not silo therapy. So that's the other thing I see as maybe a real missed opportunity. So often patients are in one silo. Well, I did pain management for 6 months. I got injections. Then I did medications for 6 months. And then I did PT for 6 months. So that's 18 months, but there's no coordination of care. They did silo, one here, then one here, and then one here. No, we need to be working together. So once you feel better, go to the PT. He'll get you a little bit more physically active. And then you can try some medication that gets you a little bit better. And then you go to the gym and get exercise physiology to do to do something different. One success begets the other, not the silo. That's the biggest mistake. I mean, all this money has been spent, I mean, appropriately, I guess, but no coordination of care. And that's what I really enjoy, is coordinating the care with the patients. And that's really key. Most patients are lost. And I would be too. It's very confusing out there. So we want to make it easy for patients to understand what's the goal. How do we coordinate with your real doctor, your primary doctor, or your chiro or PT, and then circle back with me if necessary. So we're all working together on the betterment of that one patient.
Wow. Amen. And I love what you also said about the correlation between the diagnostic testing and what the objective findings are, but also with the symptoms. Just like we had another interview with Dr. Zahir, he was talking about the same thing. Somebody can come with a horrible MRI, but if there is no pain, it's not necessarily going to be the same procedure that somebody who comes in with so much pain, and then you find out what the reason could be, and you have to do something to actually take action based on both, not just one. So I love you touched on it.
And I think you have a very good point there. A lot of patients will say, well, they can't find out what's wrong with me. So often patients will get the feeling that, well, I must be crazy, or the doctor doesn't believe me, believe me. I mean, because I can't take a meter and put it in your skin to say, oh, you've got a pain reading of 12. I can check your blood pressure, I can check your SAT, I can check, a heart rate, but I can't check your pain. It's what you're telling me.
Yes.
So that's a really key thing, is just to say, well, just describe it to me. And sometimes patients come to me, and again, I understand, well, I've got total body pain, hurts all over. Well, I understand that, but what's the worst pain we can take care of today? Because everything is kind of connected. So if you take care of the worst first, then we'll work on everything else later. So the analogy I always love is, I've been married 32 years, lovely wife, and she just puts up with me, so she's great, is that I get a honey-do list. Well, I want you to clean the garbage. I want you to clean the cans. I want you to go to the grocery store. I want you to take the kids to the park. And after that, I want you to make dinner. Okay, well, I'll get to each one. Which one do you want me to do first? And then we take it down in a small bite so I can do all those tasks. Because if I get all of them at once, it's impossible. But let me break it down into small chunks that the physician can handle, and then we can move you forward. And if most patients can understand that, that's also success, because they realize they're being listened to and they have a plan of action how to move forward.
Yeah. And they're not crazy. They're not crazy. Some people, have different pain tolerance level. And we all know this, that some people will just endure a lot of pain and will say that that's just normal. And some other people will just treat that as a 9 out of 10, maybe, whether the pain level, because it's so subjective how you perceive it. So I think it's important to listen to the patients and also have the experience to also assess, is somebody telling me the truth? Because if they just came running to my office and they say they're 10 out of 10 and they were just smiling and laughing, that's something that I'm sure that you as a physician, you can assess properly. That's important. Let's talk about a practical example. Somebody shows up at your office, okay? And let's say they have a bunch of medications that they have been prescribed before. They're confused. Maybe some of them were narcotics. They are getting a little bit affected by what they were taking. They're worried, but they know they need some. What would you do in case of medication management to prevent the use or overuse of narcotics?
Sure. Well, first thing is, again, you've started talking about this. Is narcotic therapy appropriate? Of course it is, if it's necessary. And that's where we get in a problem. We've seen a swing in the pendulum. I'm old enough to remember when I graduated medical school in 1989, I can't believe it's that long, where we were very cautious on giving out narcotic therapy because we didn't want people addicted or have real harm come to these patients. Okay, so maybe we were on this side of the aisle, we weren't giving enough. Then in the 90s, there was a big movement in the United States. It was the Right to Die movement and Jack Kevorkian. And the reason why people wanted the right to die is because their pain was undertreated. They wasn't getting the care. So I'd rather check off the planet than live in this type of pain. And this is the same time when Purdue Pharma, who's been popularized by OxyContin, came out with a long-acting, opiate-based medication. Also at this time, came up through the World Health Organization that pain should be treated, aggressively. And then, so now we see this coalescing of, we've got a medication, pain is being undertreated. We've got medical society saying pain must be treated. And now we have the government now mandating a VAS score. This is like every time you go to a hospital, what's your pain score? I'm coming from my gallbladder. I don't have any pain. No, you got it. We have to put that down now. So, and the government was then mandating almost, you need to write medications. And what do? We wrote medications, and we wrote a lot of them. And because of that, then we had people being physically harmed either by death or true addiction. And now the pendulum has swung one way we gave all this medication. Now we're back to this way. Somewhere in the middle is the right answer. So to your point, when someone comes to me with a bag of pills, I always ask, it's very confusing. Most of my patients are older. I mean, let's simplify things. Do you need all these medications? And the answer is probably no. So let's find out things that are going to work for you. But let's kind of take a scientific approach. Most people are on non-steroidal medications, Mobic, Advil, naproxen, things like that. And most times, they really don't work all that well, because if they were, they wouldn't be seeing me. Sometimes these patients are on, oxycodones, the Percocets, the Vicodin, which is hydrocodone. They might work well, but they also have cognitive side effects, in terms of their mental ability, older folk especially, or they might have GI side effects such as constipation. So I always ask people, does this medication work? Well, it helps a little, but I got all these side effects. I go, maybe we don't need that. That's gone. So then we got to replace with something better. And usually these medications are not limited to, most of these patients will have sleep issues. Sleep and pain are always interrelated. I can't tell you how much. And no one ever asks about sleep. No one. So I always ask, how you doing? Oh, pain's there. By the way, how's your sleep? Oh, it stinks. So always give them an old medication from the 1960s that are old-time antidepressants. We have known as anesthesiologists this since the 1970s. It works great for pain and their pain threshold in their brain, CNS, that those receptors, as well as help peripherally, and it is sedating. So I'm going to restore your sleep. I'm going to help your pain. So just doing that one medication, people might feel, hey, I'm 20% better. I really did nothing else but get you sleeping better, because I know that raises your pain threshold and your body has a chance to go into REM sleep where your body completely relaxes. Very important. Other medications that you could think about that might be added to that are basically like the Lyricas, Neurantins, anti-seizure medications, because pain is shooting like nerve sensation. Well, what's a seizure? Well, that's what that is. So using those medications, but only at bedtime, might be also of benefit. Now, if you notice, I've always tell people, take your medicines at bedtime. Yeah, but John, my pain's during the day. Yeah. They'll work 24 hours, because the main thing is, as a physician, we need to do is thread the needle between effects and side effects. So often I say, well, I can't take this medicine. It blows me out of the water. I'm too sleepy. That's fine. Let's take during the nighttime when you're not sleeping to help with that side effect. And sure enough, just changing the med just a small amount, all of a sudden things start to add up. And then now if they need an opiate-based therapy, that is fine. The biggest concern is the amount of medication is given in terms of the volume of pills and the milligram of the pills. Normally, you want to stick with the government, the current CDC states is safe is under 100 milliequivalent of morphine. Now, that doesn't mean you can't go over it, but it's always better to stay under. And you always want to be sure you don't combine this with a benzodiazepine, Valium, Ativan, clonazepam. All these things can cause respiratory depression, and these tend to lead to more addiction. So you have to just be cautious. Doesn't mean, again, you can't use it, but if you do write for it, you want to make sure that you do pill counts. So in other words, some patients, not all, but some, can give their medication or sell their medication or divert their medication. I'm responsible. You can't do that. So you want to really make sure that that doesn't happen. Again, it's appropriate care, but you got to do it cautiously.
Yes. Wow. So valuable information, because people need to know that not only the type of medication, but also the strategy and dosing strategy and when to take them, that can play a big role. And like you mentioned, that can also solve the sleep problem, and solving the sleep problem alone already, puts a big dent in the pain feeling. So that is important to know. So let's say there is a patient, because there may be situations like that in many different offices, that the patient comes in and says, I feel like I'm actually liking these pills too much, and I when I try to get off of them, I can't. What are their options? What can they do?
So there, to that point, which is a great point, is there's two components of addiction. One is a psychologic dependence, and that's normal. So I take the medication, I feel good, I feel markedly better. Well, this naturally sets up, well, I want more of that feeling, let me go again. And this is a normal thing. And I could see where people do that. I've had this pain, I take this, in 20 minutes, I feel markedly better. And then sometimes it's relatively short-lived, 4 or 5 hours. And then, well, let me go again. And sometimes patients will start to use the medications inappropriately. If the doctor says every, 4 times a day, it might be 5 times a day. It might be 6 times a day, because they not only help with my pain, but also really help with my overall well-being, my joy of life, things like that. Outside of my pain, actually boosted my energy a little bit. So we have to be really cautious of that. And sometimes patients will actually adulterate the medications. What does that mean? Instead of taking the pill and taking it whole, they'll crush the pill and snort it or something like that to get a bigger buzz. Again, when you start doing that, you're clearly on the wrong path, and that has to be addressed fairly quickly. And again, before even starting that, you always want to talk to patients about, what is your genetic history? Do you have any trouble with addiction yourself? Alcohol, tobacco, gambling? Your mom and your dad, do they have any troubles? Because obviously, if you are genetically predispositioned for abuse or overuse, maybe that's not the medication I should be using. Or if I do, I'm going to use it very cautiously so I don't, kindle any of those issues in terms of addiction. The other part of addiction, so one is the psychological part, makes me feel good. The other is a physical dependence. So physical dependence means if I stop taking this medication, I feel uneasy. And we see this all the time with like people who drank too much coffee. They stop coffee, next thing, that wicked headache, they're caffeine dependent. Alcohol. If I stop drinking alcohol, I get the shakes. I don't feel right. So we've always had this kind of feeling. And again, we know we are now physically dependent on this medication. Now, if that's the case, again, let the physician know, and they can certainly wean you off this medication slowly, or send you to somebody with a specialty with addiction, things like that, so it can be done safely. And again, it's nothing any bad. No one's blaming the patient or blaming the physician. It's just that, hey, I'm a little concerned about these meds. Let's back down and see how I do. And again, that's not a bad idea. And also, to the point where I truck a lot of patients, sometimes what's normal? I've been so many medications, or opiate-based therapy or other therapy. I don't know if I'm good coming or going. So sometimes we might do a detox. What's normal to you? Because sometimes you take pills to wake up and pills to put you to sleep. You're like Elvis. What's normal? And then so what we can do is say, okay, this is normal. I feel terrible. Okay, good. This is your baseline. Then we can kind of bring you up or change as needed. But those are really good points. And some patients, if we do find them inappropriately using the medications, like using them too frequently, buying medications from someone else, trading medications, snorting medications. Again, these are real red flag sign of addiction that they really need to see, an addictionologist, psychiatrist, perhaps even go to a detox type of facility. So there's kind of, where a kind of lockdown care. Some people can do this on their own, but when you're on your own, you don't really have any backup. You can always cheat, but when you're in a 30-day program like Tranquility Woods, which is great, which is in Pasadena, they are, it's a 30-day program where you are counseled, get good medical care. And then more importantly, they talk about like, why did you start using these medications? Again, a lot of these patients have underlying depression, underlying anxiety, underlying internal hurt that pain medication certainly makes you feel better, but it won't fix. So patients want to fill up that hole. I got to fill it up with something. sometimes it's alcohol, sometimes it's sex, sometimes it's, medications. But then we got to figure out, well, again, I'm not a psychiatrist, but we got to figure out, well, what's more appropriate? What other techniques can you use to fill up that hurt, to fill up that hole? So that's where you start the process.
Wow. Thank you for the answer. And it's good to know that people can go first to the physician. I mean, first they need to self-assess, I guess, if there is a reason to be concerned. But if they are, they should contact a physician, let them know what they feel, how they feel, and also let the physician also guide them, because I'm assuming that your ability to make decisions when you're on a lot of drugs may be impaired quite a bit. So if they go to somebody with a lot of experience, you can sort it out for them and say, hey, maybe it's not that bad. Here's the strategy. Here's step 1, step 2, step 3, where you already said that there are a lot of different steps that they can take, from the dosing strategy, getting you off, finding out what your base, also seeing a specialist, switching the drug, going to a facility. So there are a lot of options, but the key for people to remember, if there are people, because I know there are physicians watching, but also individuals as well. If you know somebody who is struggling, have them see the pain management doctor first to help them assess what to do next.
Right, because now you've kind of, indirectly caused the pain management has caused two problems. Number one, I still got the chronic pain, and now I've got an addiction on top of this. How to get better? So what you have to do is say, okay, so, and actually I've done some speaking at the addiction societies, because a lot of these patients I see in the methadone clinic, some of them were in the wrong basement at the wrong time, and they're just using medications recreationally. They just want to have fun, and they got stuck. But another portion of it, these are really people that had chronic back pain after surgery that didn't really work very well, or knee pain after knee replacements. So the orthopedist says, well, there's nothing really wrong. It looks fine. Your x-rays look great. So that's great. But I still got pain, doc. I don't care what my x-ray shows. And then, so, well, here's your medication. So then they get stuck. Or what happens is the surgeon or a physician would write medication. And after a while, 6 months, maybe a year, now it's like, whoa, what have I been doing? Now I'm uncomfortable. And then they say, well, we're going to stop this medication. But now if they do, that patient is now physically dependent, maybe even psychologically dependent. So you've really left them in a really bad place for a patient. Just all of a sudden kind of pull the rug out from them. They go, well, I can't do this anymore. Best of luck. That's not fair.
Yeah, it is definitely. And it's good to know that you can support, and there are also other facilities and options for treatment, because sometimes a little bit of treatment can, go a long way. Let's talk about injections, please, because when people hear pain management, some people think medications, some people think injections, and sometimes they put injections in just one category. Yeah, I just got a pain management shot, right?
Right.
But okay, which one? Where? How many? And let's talk about it, and let's decipher it for people. Let's talk about the options when it comes to pain management injections, and also what do you do in the practice?
Sure. Well, I mean, as an anesthesiologist, obviously injections are kind of part and parcel to what I do. Attorneys have legal pads, accountants have calculators, and anesthesiologists, we have needles. I mean, but the other thing is just because this is what I do does not mean that's what you have to do as a patient. The patient always has the ability to say, no, that's not for me. Okay, fine. But that is an option. So obviously what you would want to do before anything is, going back to what we said earlier, is a history and a physical. Where does it hurt the most? Most people have back pain. Most people that I see are older folk. Why? Because, well, that's who's got back pain, older folk. Now, granted, there might be some issues with cancer pains or other issues, but let's stick with the most common. Most older folk have back pain. It hurts for them to stand for long periods of time. It hurts for them to arch back. It feels better when they're on the shopping cart to lean forward. This is usually related to just age-related arthritis of the joints of the spine, or lumbar stenosis. That means a narrowing of the spine. For that particular, and do you have leg pain? Not really. Maybe it goes to my butt, maybe back of the thigh, but not to my foot. And that's a big difference. I'll tell you the reason. So for those patients who just have the back pain, most likely it's called a facet injection. Been around since the 50s. And again, what you would do, go to a physician. They would have most likely a fluoroscopy suite in their office to keep the cost to a minimum. You get an injection directly under local anesthesia. A lot of places do IV sedation. As an anesthesiologist, I think that's a little aggressive. It's not necessary. If you know what you're doing, you don't need to be asleep. And obviously having an awake patient is really key for your safety. And obviously safety is the first factor. So what you would do under x-ray guidance, I would touch the patient under x-ray. Is this where the pain is? I can see it under x-ray. That's my target. 2 bee stings, done. So it takes about a minute to do. It's as bad as a flu shot, I'll be honest with you. And it's no more than a minute. And then the patients go home and they would come back in a week or two, tell me, how are they doing? You know, granted, I like to know that their pain score is down, but I like to hear about your functionality. Oh yeah, I'm still at 10, but no, I'm back to the gym. I'm doing my house cleaning. I'm doing the kids with the mall and all that. That's what I care about, is your functionality. So if you came back and you got better, and again, better, can we talk about that? What is the definition of better? 50%, 2%, 100%, rarely 100%, but at least 50. And if we get you better, well, now we have a diagnosis. This is where the pain is coming from. Stop treating the x-ray, start treating the patient. Then we can come up with a plan of physical therapy or exercise routine for that one problem. Now, let's just say the patient say, well, you know what? It's in my back, but it's sciatica. When you say the word sciatica, by definition, you mean down the leg, runs all the way down like a lightning bolt. You hit your funny bone here, it runs all the way down to my little finger. So we know that's a nerve always. And the patient can always tell us where the pain is located, and they will show me how it runs down their leg. And you just have to just show me, and then we'll know what particular nerve is involved. And if that's the case, simple idea, x-ray room, clean your back off, find the hole where that nerve comes out of, inject the steroid medications there, done. And it's a similar idea in terms of it takes about a day or two to work. Tell me about your functionality. The other thing I want to kind of clear up, and this is a great opportunity, is most physicians, and again, it's very inside baseball, think every back injection is an epidural. That's false. And we don't do epidurals anymore. Epidurals, we stopped doing those in the 90s, honestly. So what we normally would do is, it's been such great marketing. It's like, well, that's a Kleenex. No, it's called a facial tissue. Or give me a Coke. Well, you mean a brown caffeinated cola beverage. It became the product. So you really have to be specific. So for people with localized back pain or localized neck pain, and localized meaning neck and shoulder, low back to butt, that's most likely a facet problem. If it runs places, like we talked about down the leg or down our arm, that's a nerve root problem. And that's really kind of the two factors that come into play. And again, once you do the diagnostic injection, it's not only diagnostic, but also therapeutic. But we'd also add the medications just to have some backfill, because I know one complements the other. Now, the other argument might be, well, John, how do you know which one made me better, the medicine or the injection? And that's a great question. But in my experience of like almost 30 years now, we're not running lab rats here. We're running patients, and patients need both types of therapy. And again, sometimes people say, hey, I'm doing great with the injections. Do I still need the medication? And I would say, well, let's find out. If you stop the medication and the pain comes back, well, I guess you needed it. Or if you stop the medication, you're still doing great. Great, stop the medication. So we really kind of tailor it to that patient's experience. And that's really key. But again, the big take home message is, make sure when you want an injection, what type of injection are you doing? Again, cervical meaning neck facets, lumbar facets meaning low back, or is it called a nerve root injection? And by definition, it's called a selective nerve root injection is a real term. So not every injection is an epidural. And the reason why epidural is the way anesthesiologists do it, just like for OB, you put a needle straight down the middle of the back and kind of flood the field with a bunch of steroids. And again, we really don't want to do that, because it's not diagnostic, because it's making everything better. And you're really using high dose steroids. So steroids are not bad, but we have to be cautious on how much we give in terms of steroids. Steroids have their benefit, but also have their risk of exposure to steroids with high dose and long-term exposure would be like poor wound healing, increased chance of osteoporosis, diabetes, immunosuppression, greater chance of infection, and then diabetes and weight gain. So if you have lupus or rheumatoid arthritis or some sort of immuno issue, well, yeah, I guess I got to use steroids, but not in my field. You have to be very cautious.
Yes, and that ties in. Thank you so much for that answer. Ties into the thread that you mentioned, that you're feeding the thread in between the, the effect and the side effect, and we need to know where that balance is and which one to use. So now I understand that there is a big difference between a localized pain where there is going to be most likely facet injection needed, or a pain that is related to a nerve root where we're going to be talking about a different injection. I wanted to go a little bit deeper, and right now probably more for providers because we have some providers watching.
Sure.
And by the way, if you have any questions to Dr. Dombrowski about your patients, feel free to comment below or connect directly in the messenger or otherwise, or let us know to make a connection. So I wanted to talk about another therapy that I saw in one of your videos, which was very interesting to see, the spacer for facets, right? So we are talking about something that is also minimally invasive, still can have long-term effect, can be, in contrary to fusion, can be removed if needed. And I wanted to talk about this one because I find it very fascinating. And some people, especially we are talking about rehab specialists, chiropractors, some people already know about this. Some people may not know that it's around the corner as an option. So let's talk about that, please.
Right. So what you're speaking of, so as we mature, the disc space get a little bit lower. So in other words, instead of being this far, they get a little bit this far. And as they kind of pinch that nerve, it causes a lot of low back pain, tired legs, and things like that. So what a lot of times you would see a classic lumbar spine surgeon, orthopedic or neurosurgeon, and they would definitely remove all the bones, and that's called the lumbar decompression. And that has been around since at least the 50s. But now we're trying to do things more minimally invasive. And as an anesthesiologist who practices in this, I want to make sure I can reverse if we have a trouble. Most surgeries, you can't reverse. You buy the whole enchilada hoping for a good outcome. And if it doesn't work, oh, well, we tried. So you always want to be, especially with pain patients, where this is a therapy that can help. But if you don't like it, we can reverse it and you're anatomically the same. And that's a really key factor. So with the spacer, basically all of that does, it goes in between the two bones, separates them like that, kind of recreates that height for that nerve to kind of come out of. And that's essentially it. It's called the Aurora Zip ZIP procedure. There's other spacers, I'm sure, but that's the one that I use. Again, for this particular patient, you want to make sure that you have an MRI that says that you have a problem at that one particular level. Again, it is an incision that is made to identify those bones. So obviously you got to go below the skin and below the muscles, identify the bones, separate them, put the space between one and the other, and then it separates that disc space, a few millimeters to give you that comfort for that, leg and back pain. We don't want to reverse them, but say for whatever reason, 6 months from now or 6 years from now, there's a cure for back pain, but we could take that out and you're anatomically the same. I really can't say that with, fusion. Once they put the screws in, the rods, the screws, you're kind of done. And that's that. So again, we try to be very cautious.
Yeah, this is amazing to know about the technologies like this. And that's why I wanted to bring this one up, especially when we talk about recovery time with fusion, comparing to a couple of weeks that you mentioned with the spacer, and much less invasive. So very, very interesting. If you don't mind, tell us a little bit more about some technologies that maybe are, the latest and greatest in pain management, that they're not as popular. I'm very curious what you're going to say.
So two things that come up, and one it's always been high on my list is a tool called spinal stimulation. So we know that the way nerves work are through electrical energy. The way our heart works is by electrical signals. Similar idea. Sometimes as an anesthesiologist, we'll try using medications to turn off the signal of the pain, injections to turn off the signal of the pain, maybe even seeing a surgeon to change the nerves to turn off the signal of the pain. And sometimes it doesn't work. So, and sometimes the medications aren't really helpful or there are too many darn side effects. So what do I do? Well, since the 1970s, and every year it gets a little bit better and a little bit better because it's America, it always gets better. You can put in an epidural, and I'll use the word epidural catheter because this is what it is. It's the same thing I would do in an obstetrical suite. The catheter goes in, the tube, and it has little metal contacts on it. Those little metal contacts conduct electricity to take away the pain in the back, in the legs, and the neck, and the arms, even belly pain. So people with chronic pancreatitis, chronic inflammatory bowel disease, or things like that, and they've been worked up 6 ways to Sunday. All these types of things. The other one that has been really just diagnosed or approved for from the FDA is peripheral neuropathy. How many people know about peripheral neuropathy? The podiatrists, the chiropractors, the PT, the oncologists who've given chemotherapy. Now you've left with, chemo-induced neuropathy, AIDS neuropathy, and idiopathic means we don't know neuropathy. Okay, they've tried the Lyricas, they've tried the anti-seizure medications. There's no injection for these people. But how about we do a trial of stimulation? And the great news about this is you get to try it out. You didn't buy anything. So in other words, the car that you took out, you didn't plunk down 30 grand. You took it out for a test drive. Do you like the steering? Do you like the handling? How's the radio? I like the seat. At the end of your test drive, you bring it back and say, I don't like this. Show me something else. Similar with medicine. I can't believe it. I could put this in the office. You try it for a week. Come back and you tell me, did you notice a difference? If you did, you now have a solution for your problem. If you don't, we'll come up with something else. And the other thing is that I like is that this is always done by an anesthesiologist with a certain skill set. So you can do the trial in the office. Again, keep the cost minimum, no sedation, no nothing. And then if you do like the implant, well, you go to a surgery center and the sedation is minimal because a lot of the patients I deal with are old and sick. So their biggest risk is not the surgery, but it's anesthesia. So they have to be very cautious. So if it's done during a local, they're not asleep, or if it's done under very light sedation, it's okay. So for older folk, it's a great idea. So that's a really great technology. And every time it's always come up new. And the side point to that is recently there's been a real boon with respect to total knee or hip replacements, shoulder replacements that have failed. Well, they still work, but the patient still has pain. So what do? They go to the orthopedist. Your components look fine. There's nothing for me to do. You've got metal, but yet you still got pain. So that's when you would see an anesthesiologist and they can do a thing called peripheral nerve stimulation. So in stimulating the whole back or the whole leg, we're just doing one small area around the knee that they need done, or around the shoulder that they need done. And again, the company that does this is called NALU, N-A-L-U, and you can look it up on the internet there. It's relatively new because this is new technology. Again, great point about this, you get to try it out. If you like it, you have a solution for it. If you don't like it, we'll come up with another plan for you. So that's another real exciting news. Spinal stimulation for central pain, neck, arms, back, legs, belly, and or peripheral nerve stimulation for just one small area that needs it, usually for total joint replacements.
I love this. I love the options that people have because the technology always allows us for more opportunities. And just like, being able to use a very sophisticated smartphone right now allows you to do so many different things. Now, with the advancement of technology, we are able to treat patients that otherwise maybe wouldn't even like to live because the quality of life is so bad. So very interesting, not only the technology of the spinal cord stimulation, which I heard about before, I knew about the trial, but I didn't know that you can use it also for a total knee replacement and for other areas than just the back. So very, very interesting. I wanted to ask you one very important question, and that is, how do you see the advancement, not in technology in this case, but in the integrative medicine approach that I know you practice, that this is like your Bible, and that's why we all respect you so much, is because you know that it's not one provider that is in the mix for patient betterment, but it's the multiple, and also the active communication. And I can't even explain how important it is for people to be able to reach each other. And I'm talking about providers. If you're a chiropractor watching this and you need a pain management doctor, you don't want to have a 17 layer of assistance before you ask you get the answer for your question. And I know you practice it. So let's talk about the advancement of that process. I know it's not where it needs to be, and we are all trying to promote that kind of approach. Let's talk about how it is in your practice and what do you think about it?
So, I mean, again, I can't agree with you more, but I think what we always do with my practice is set patient expectations. You're better. Great. What are you going to do now? What are you physically going to do now? And I'm not a physical therapist. I'm not a chiropractor. I'm not I don't do exercise hardening. I don't do any of that. But I know that's the goal here. Being out of pain, well, that's laudatory. I got that. But I want you functioning. Having you completely comfortable on the couch watching the Flintstones, that's not a win. A win is when that's why I always ask, what do you want to do? What are your goals as a patient? What activities do you want to be doing again? I want to go golf again. Or I want to spend my time with my grandkids, or I want to take that vacation that's so special. I don't want to be too sedated. Okay, we will get you all that. But once we get you feeling a little bit better, show you that little window that just opened up a little bit. Now do the physical therapy. Now do the chiro. Now do these other things to get you that next level. So what happens is sometimes patients plateau. So in other words, I'm stuck. I've done the PT. It's not really working. Okay, let's get the injection. Change your medication. Boom. Now you're up here. So and then let's well how you doing now with the physicality? Oh, much better. But I'm getting a plateau. Great. Boom, up here. So each time we move the patient down. But how do you do that? It's always coordination of care, and that's why I'm always asking the patient, who do you see? Who are your providers? So I'm writing them, all of them write a letter, I mean, they may not read them, but I'm writing them. So this way they can, understand if people need to call me, everyone has my cell phone number. I mean, this is how and important it is, because to manage that patient, you need that coordination of care. Now with these big Uber systems like the MedStars or the Hopkins, they're very good, but they're behemoths. And what happens is it's the smaller practices, like probably watch this video, that are more nimble. And it's usually the nimble ones that tend to survive or tend to be more entrepreneurial, could do things more specific for that one patient versus one size fits all MedStar, one size fits all Hopkins. Maybe it does work. I don't know, but I don't like practicing that way because there's too much control. It doesn't really work that well. Patients are always unique and different.
And they really are. And thank you so much. And talking about unique, you are a very, you know this, but I will tell you again, you are a very unique practitioner of medicine. You're a very unique provider. You're a very unique person, and we are proud to have you in the group. To everybody watching, thank you so much for watching. And thank you, Dr. Dombrowski, for sharing your wisdom, your knowledge, your tips, and also a little bit of your, it's like the door to your world. So we understand how the world of a experienced pain management specialist looks like. And for all of you watching, what are we building with Polish Your Life? We are building a network of practitioners, of providers, but also people, because so many people go from doctor to doctor. Sometimes they follow recommendations and they still don't feel better. And that's not right. We don't like it. We want to help these people. So what we are building, imagine 10,000 healthcare providers and individuals sharing clinical experience, referring to each other, and that's all for the best results for the patient. So we are on our way. We are not at 10,000 yet, but if you know somebody who needs to connect with us, healthcare provider, or an individual who is really looking for clinical solutions, connect them with us. Follow us if you're watching on, Facebook, Instagram. Subscribe if you're watching on YouTube. Definitely connect with Dr. John Dombrowski. Dr. John, where can people find you?
So I do have a website. It's dcpaindoc.com. So DC is District of Columbia, paindoc.com. I am on Facebook. I really don't do a lot of posting there, but the website has a lot of, I think, pretty good instructional videos. A welcome video tells you every procedure that we are able to offer in the practice. And obviously it's a way of booking appointments, and I appreciate the plug. Thank you.
This is awesome. Thank you so much, Dr. D. Thank you so much for watching. Wishing everyone a great day and a healthy day too.
Thank you.